Hello, I'm Valerie Cordero, Co-Executive Director of Families for Depression Awareness, and it gives me great pleasure to welcome you to our webinar entitled Sharing Mental Health Information in Your Family. We have a really special presentation in store, so I hope you are ready to learn from our experts. If you feel comfortable as people are coming in, feel free to say hi in the chat. I see folks coming in. Go ahead and say hi. You can even say where you're from as folks are coming in. I'm waiting to see in the chat. Anyone want to say hello and where they're from? I know it's a little bit intimidating sometimes in these groups, but feel free to say hi. And we will be having information shared in the chat as we go forward in the presentation. But again, as you're coming in, you're welcome to say hi and say where you're from and maybe even what you're hoping to learn. We know that the question and answer period of any of our webinars is what people really look forward to. So I just want to let you know that we will be pulling questions both from the pre-registration that you completed and questions that are asked live during the presentation. So feel free to use the Q&A function to ask any questions that you may have, and our experts will address it once we get to the end of the presentation. We have a wealth of information to share with you, so take as many notes as you can. We're also going to share a PDF of the slides in the chat. So if you're following along and you miss a term or a statistic or some information, don't worry, you can get the PDF of the slides, download it, and then you have that information to come. Just also want to remind you that after the webinar, there will be an online evaluation that you can fill out. We value your feedback. We do read every single evaluation that we receive, and it allows us to plan our programming and improve our programming going forward. Everyone who fills out the evaluation for this webinar will be entered for a chance to win Kenyatta Berry's book, The Family Tree Toolkit. So be sure to do that at the end of the program. If this webinar is helpful to you, please do share the link when it becomes available to friends, colleagues, family. It will be on our website in our webinar archive, so you will be able to look for that and share it with others. So we're going to now learn a little bit about Families for Depression Awareness. We are a national nonprofit organization. We help families recognize and cope with depression and bipolar disorder to get people well and prevent suicides. We really do believe that mood disorders are a family issue. So if dad is living with depression and really down and going through a depressed episode, then mom might be doing more around the house, doing more with the kids, and she may be overwhelmed. The kids may know something's wrong with dad, but they can't put their finger on it, and they become more withdrawn and isolating. So that's just an example of how we really do truly believe that that mood disorders affect the whole family, which is why we exist and why we want to support family caregivers through our programming. The hub of our resources is our website, familyaware.org. If you came to this webinar, you might have already seen the website, having registered there. If you haven't been to our website, I really encourage you to take a look. We have very important information, interviews, family stories. We have our online tools and so many things that are geared specifically towards family caregivers and can help. One tool I want to particularly highlight is our mental health family tree tool. We spent some significant time updating it recently, and it's very appropriate for our subject matter tonight. If you learn a lot from what you hear today, you may want to go and use our mental health family tree tool. It is completely free, and you can fill in information about yourself, about your loved ones, up to a certain degree of family of extended family, and that information can be printed out and brought to a clinician for further evaluation or to help with information and health history. We have a webinar archive, as I mentioned earlier, where you can see some of our previous webinars, and they're recorded. You can get lots of great information on topics such as teen self-injury, as setting boundaries, communication. So definitely check that out at familyaware.org/trainings. We have some excellent publications on all different topics related to mood disorders. And I particularly want to highlight our handbook for caregivers. It's really quite excellent. So you can find that on our website as well. So our agenda for today, we are going to hear from our two expert presenters, Dr. Bruce Cohen and Kenyatta Berry. Dr. Cohen's going to begin talking about understanding the role of genetics in family mental health, talking about heredity and mental health and how this information can apply to your family. And then Kenyatta Berry is going to share her insights on how you can gather family mental health history and some tips on getting around maybe sticky situations or difficult conversations related to family mental health history. We'll end with some further resources, the Q&A, of course, and then we will push out the survey. So before I introduce our presenters, we want to get a quick poll. We want to find some things out from the audience. And so I'm going to see if everyone can let us know how much you know about gathering and sharing family mental health history. So please take a moment and answer this question. All right, got some answers coming in. I'll give you maybe another 10 seconds. A couple more answers trickling in. All right. Let's look at the results together. So we have 25% of people say a good amount. So there is a population of folks here who have some knowledge. Most people overwhelmingly have some knowledge, but maybe have come here to learn more, which is fantastic. And there are a few of you who know maybe very little about gathering family mental health history. So we definitely understand that. You are welcome. Everybody is here to learn. So we are excited to have you with us. At this point, I would like to introduce our presenters, and I will read you their information. Dr. Bruce Cohen is the Robertson Steele Professor of Psychiatry at Harvard Medical School and the President and Psychiatrist in Chief Emeritus at McLean Hospital, Mass General Brigham. Currently, as Director of the Program for Neuropsychiatric Research at McLean, Dr. Cohen leads a consortium of investigators and clinicians using laboratory, brain imaging, and clinical research studies to increase understanding and develop new treatments for psychiatric disorders. At McLean, he was the co-founder of the McLean Clinical Research Center, founding director of the McLean Brain Imaging Center, and director of the McLean Residency Training Program before becoming president of the hospital. Kenyatta D. Berry is the author of the Family Tree Tool and a contributor to the groundbreaking 1619 Project, published by the New York Times. She was also the genealogist for the 1619 docuseries on Hulu. Kenyatta is an author, attorney, lecturer, professional genealogist, and television personality. She was the 2019 honorary chair for Preservation Week and was named a newsmaker in American Libraries Magazine, the American Library Association publication. Kenyatta's vast knowledge in African American genealogy, enslaved ancestral research, and DNA have made her an invaluable research. With that having been said, I'm going to turn the program over to Dr. Bruce Cohen.
Thank you, Valerie. And I'd like to thank Families for Depression Awareness for the invitation to speak. As Valerie said, there are a lot of questions. We can't answer all of them, but if you have material that you see that is hard to understand, please don't be afraid to ask. Most geneticists don't really fully understand genetics either, and I would include myself amongst those. Put myself in the know a fair amount or a great deal, but certainly there's much about genetics that nobody understands yet. So going into the background, it's true about human beings that in a way everything about us is partly genetically determined. That's, after all, why we're related to one another as human beings. And we're a lot more alike than we're different, despite what some people might think. We're mostly, we're all of a kind. And it's not just what we inherit in our genes that makes us who we are. It's our environment, it's our activities, it's our experiences that all matter. And this is very important. We're all born with some degree of risk for or resilience against being sick in one way or another, or having a psychiatric disorder in particular. And that's true for how susceptible you are to getting a virus infection, or whether it's a depression. So inherited genetic factors are a big part of that, but not everything. So what kinds of things are shared and handed down within families? Because to some degree, we're not really capable of analyzing everybody's DNA and telling you exactly what genes you have and how they interact and what the outcome will be. What we see in a family is all of the factors that I just mentioned, which is shared environment, or for that matter, different environment between different members of the family. Some go on for college, some do not. Some get a job in a factory and some get a job in a university. Rearing is extremely important. Valerie mentioned that anyone in the family having any illness affects everybody in the family. That's one factor. Another factor is the way your parents treat their children affects all the children. And for that matter, the way the children treat the parents affects the parents. And then there's the DNA, the deoxynucleic acid, which contains our genes, all of the factors and their interactions. None of them stand alone. Their interactions determine our risk for health and illness. Next, please. So what are genes? You may be surprised, some, if I tell you that there isn't an entirely clear definition of what a gene is. Gene is an old word, and it's a concept from over 100 years ago, when people thought that you inherited a few simple factors and they determined your traits. For example, Mendel Lamarck, who grew peas, and some peas were taller and some were shorter and some were crinkled and some were smooth. He happened to pick traits that are determined by very few genes, but very few traits are like that. Genes, as we understand them, are sections of our DNA, and that's the inherited molecule. You get one set of DNA from your mother and one set of DNA from your father. And the DNA contains information for making specific molecular elements of our bodies. These are things like proteins, but they also indirectly create all the other metabolic elements, chemical elements of which we are made. But they're not just coding for structure of some molecule. They also regulate the making of those elements. So a gene is not something you inherit and you just have it for your whole life, so much as it's something you inherit as a possibility, and it turns on and off. And the turning on and off is very important, because exactly what happens when we're under stress, or we change our diet, or we start to exercise, is the genes turn on and off. And that changes some of what constitutes our brain, or for that matter, our liver, or our lungs. Next, please. So this just shows that in a schematic. You'll see the genes are really at the very bottom, while up at the top, where I said circuits and activities, that would include things like mood, or really a little above that, because these are conscious things, mood and thinking and behavior. So between your genes and the activities of your brain is the genes make a molecule RNA, which is essentially the same as the DNA with a slight molecular difference. The RNA has the information for making the protein. The proteins are components of the cells. And of course, the cells make up the brain. Meanwhile, as you see on the right side, there are all kinds of outside influences that alter any level of brain elements. And those are the things we call environment. And that includes all of our interactions with people and all of our interactions with everything else around us. So this is very important, because I have a friend who also got a PhD in genetics and still tends to think of most traits as being from single genes. So I inherited my mother's eyes because of a gene. I inherited my father's nose because of a gene. This is rarely true. There are very, very few human traits that are related to single genes. Most things about us are determined in part by interactions among hundreds or even thousands of genes. And even the things you think of as very simple, like eye color, 16 genes have already been discovered that contribute to determining eye color, hundreds of genes for hair color, and for high-level functions like what is called general intelligence, thousands of genes. So too with medical conditions. Now, Huntington's disease and a few others, sickle cell disease, determined by one gene. Type 2, which says tile there, I see. My mistake, I apologize. Type 2 diabetes mellitus is determined by hundreds of genes, with none of the genes determining more than a little bit of risk. Same thing is true with psychiatric disorders. I cite the schizophrenias here because they have been the most studied. Thousands of genes are estimated to determine the risk for schizophrenia, with the most important gene in determining risk only determining maybe 2-3% of risk. Depression is less well laid out, but we know there are hundreds of genes at least that contribute to mood disorders. Next, please. So, how much do relatives share our genes? Now, you may remember this from school, but like most things, if we don't think about it a lot, we easily forget. So half our genes come from our mothers, half come from our fathers. It's a touch more complex than that, depending whether the other factors are involved. But the X chromosome and the Y chromosome in particular don't have the same number of genes. So men and women are a little bit different in that regard in terms of how many genes come from which source. But roughly half our genes are shared with our so-called first-degree relatives, our parents, our siblings, and our children. And if you do the math on that, it's because of the way the genes are shared down. But if you go one more link out to your uncles, your aunts, your grandparents, you only share a quarter of your genes with them. And if you go out to your cousins, it's 1/8 or less. So as a simple matter of logic, when you're asking questions about genetic risks, which is not the same thing as familial risk, what you see in parents, siblings, and children matter most. Shared environments may be more the same across a larger family unit. Next, please. So these are heritabilities, just to give you some background on for comparison with the psychiatric disorders. We say here heritability of some physical illnesses, and physical is an odd term. I think we mean medical disorders other than psychiatric disorders, because psychiatric disorders have physical elements too, of course. But these are things like diabetes, hypertension, high blood pressure, irritable bowel, breast cancer, ischemic stroke, all shown. And as you can see, they vary, but they tend to be between about 25% and about 70%. And on our average, they come in maybe a little lower than 50%. So you can say about 50% of our risk for these illnesses is due to genetic factors. With stroke, it's a little different between men and women, and that's why it says MF at the bottom. In men, stroke is a little less determined by heritability, and in women, a little more determined by genes. Next, please. So these are some psychiatric disorders. Not everything is on here, and most of what's on here is simply because they're the disorders that have been most studied. So up at the top is major depression, so-called, in Europe, unipolar depression. But these are the depressions that really cause trouble for people, get in the way of their lives. You'll also see the little M and F, and that's because the 29 to 42% indicates that when you do surveys, you see less genetic risk determination for depression in men than in women. Take that with a grain of salt, because we all know that men and women do not express themselves necessarily the same way. Bipolar disorders, which are another form of mood disorder, much higher proportion of risk is determined by genes. Some studies even went as high in twins as 100%, but 73 to 93%. Panic disorders are very common. Almost 50% on average. Schizophrenia is also quite high in how much is determined by genes. Personality disorders is very interesting. I do not mean personality traits. I mean here where people have an extreme enough personality issue that it causes a problem in their relationships, their work, their lives. Those are also highly inherited. B refers to a group of personality disorders defined by a panel of experts that are very strangely called antisocial, borderline, histrionic, and narcissistic. They mostly share the same features, and that's what this refers to. I cited suicidal behaviors because it's very important to note that feeling suicidal or taking action on those feelings cuts across all of the psychiatric disorders. The highest rates are actually in people with panic disorders, but are very high in depression and bipolar disorders. And there are heritable factors for suicidal thoughts and behaviors associated with those thoughts, which may be as high as 50%. Next, please. Okay, again, to me, this is very important. That psychiatric disorders, you don't cross a line between being okay and not being okay for many medical disorders. Think of high blood pressure. There really isn't a cutoff. The agencies that talk about high blood pressure have to set some cutoffs. But what's a high blood pressure in one person may not be the same as in another. Same thing with blood sugar in diabetes mellitus. It's a scale. You either have higher sugar or lower sugar. You either have a higher blood pressure or a lower blood pressure. Also, excuse me, all psychiatric disorders are like that. And everyone has some genes associated with psychiatric disorders. They're just normal human variants. And everyone is at risk or susceptible to some degree. Some of us have more symptoms. We, again, only make a diagnosis when what's going on for somebody is leading to a real problem in their life. Next, please. So these are some rates, and these two I would take with a grain of salt because these are from doing surveys in populations, and a surveyor doesn't always get a good answer from people being surveyed. And a lot of people are not all that interested in telling you if they have a problem or someone in the family has a problem. And obviously, Kenyatta is going to talk about that a lot more in families. In any event, general population rates are shown under that column. Major depression is pretty common. It's at least 10% of the population at any given time, and it's been estimated in a lifetime it may be almost a quarter. Bipolar disorder is not as common, but some people think as high as 5%. Panic disorder, similarly. Alcoholism specifically, or other substance abuse may be as high, more in men than in women. And schizophrenia is not really very common if one uses the limited diagnosis. By comparison, first-degree relatives are in each case at a higher risk. So for major depression, 21 to 10, a risk factor of about 2 in these studies. Bipolar disorder, the risk ratio much higher, over 10, around 10 for panic disorder, maybe 5 for alcoholism, and about 5 for schizophrenia. Next, thanks. Now, when we say that people are inheriting risks for these disorders, we should be careful because there's no gene, as I mentioned, for schizophrenia. There's no gene for bipolar disorder or major depression, just a bunch of genes. And crucially, the genes for all of these disorders overlap substantially. So between bipolar disorders and schizophrenia, the overlap is about 80%. Between major depressions and bipolar disorders, similarly, it's around 70%. And even between major depressions and schizophrenia, it's in a similar range. And anxiety disorders, at least if you're a clinician, as I am, you rarely see someone with depression with no anxiety or somebody with severe anxiety with no mood disorder. So these conditions not only overlap in symptoms, as you probably know, they also overlap substantially in their genes. Next, please. Now, this is important too. I talk a lot to professional groups, to lay groups, to people with lived experience. And one of the things we talk about is the issue of the stigma of these disorders. It's important to understand about mood disorders in particular, but this is true of other psychiatric disorders. Mood disorders overlap with a lot of other disorders. Of course, they overlap with substance use and personality disorders and share genes, but they also overlap with other medical disorders. So gastrointestinal disorders overlap with mood disorders. Autoimmune disorders do. Cardiovascular disorders do. The evidence on diabetes is a little less clear, but it leans towards the direction of thinking that diabetes too overlaps with mood disorders. And there are a few others for which the evidence is still forming. It's part of the general background that teaches us that everything we do has a physical background. We're not purely that, but physical background is very important. And the physical background can either make you resilient or put you at some susceptibility for a whole bunch of conditions. Next, please. All right, what does this mean to the family? So just as we look more like our relatives than the average person, we tend to speak the same language as our relatives, often tell the same jokes as our relatives. We are more likely to have mood, thought, and personality traits like our relatives. And we're more likely to have mood disorders, thought disorders, and personality disorders like our relatives. The clues to what genetic determinants, or perhaps, again, we should say familial determinants, are running in our families include evidence about psychiatric disorders, but also medical conditions, and any behavioral or social issues that suggest there might be a psychiatric disorder or suggest psychiatric symptoms. Gathering that information has a number of purposes. Being open in a family can be very, very helpful, though one has to be careful, but it increases family understanding and supports accurate diagnosis. I always talk to the people I treat, the people I assess, and the people with whom I talk about the reason they came to the office. I always talk about family. And if they will let me talk to a close relative, I also talk to the close relative too. Next, please. And then back to this point, genetics versus family history. In researching the family history, it's important to be thorough. It's important to try to get information from more than one source, which, as I mentioned, I try to do. This second one is tricky. And I put this out there because people need to remember it. I know that you really do know it, but then it's something that people often don't want to deal with. You don't have to, but you should remember that a designated father, any place in the family, is not always the biological father. There are estimates of rates, and they're not small. And that family history and genetics are not the same thing. Family similarities are determined, once again, by shared environments, experiences, rearing practices, not just genes. Next, please. Genetic testing. This is something that we hope to be able to do, but we cannot do accurately for psychiatric disorders at this time. And that's because we don't have enough information and because no simple set of genes teaches us enough about what might be going on in an individual. There are companies that offer genetic tests to provide information on risk of illness, diagnosis, choice of treatment for psychiatric disorders, and especially they're pushing that for depression. The FDA has not only advised that these tests not be used, they have sent out warnings to doctors that using those tests is dangerous because they may mislead you. So I would just leave with you the thought that genetic tests are not generally to be used for these purposes. The American Psychiatric Association has just completed a review of these tests and has confirmed again that the evidence is inadequate to use these for clinical treatment. So they do not detect major determinants of illness or treatment response and cannot guide you at this time, perhaps in another decade. Next, please. Lastly, genes are not our destiny, nor are psychiatric disorders. Genes are indirectly associated with resiliencies and susceptibilities. Many psychiatrists include family history information in their evaluations, diagnoses, and treatment recommendations. Some psychiatrists will provide consultations on family history and genetics, But as always, when you go to a specialist or a subspecialist, make sure the credentials are reasonable, and that whatever you learn is shared with your primary care people. Next, please. I think that's the end of what I have to say. I hope that was helpful.
It was great. Thank you so much, Dr. Cohen. And as we get ready to hear from Kenyatta Berry, we're so excited for everything she's going to share. We're going to do one more quick poll. The chat is open, by the way. If you wanted to put something in the chat earlier and you weren't able to, we have fixed that. But we want to ask a question about how comfortable you are talking about mental health with your family. Let's get that question answered before Kenyatta begins. Okay, looking like most people are pretty comfortable. We have some that aren't quite as comfortable. Still waiting for a couple people to answer. Okay, about 5 more seconds. All right. So it looks like we have pretty well on one end of most people feeling comfortable or very comfortable talking about mental health with their family. That's good. 19% of you are only somewhat comfortable. And perhaps after Kenyatta speaks, we have some more tools and tricks for you all who are not that comfortable to know how to approach these conversations. So with that having been said, I'll give it over to Kenyatta.
Thank you, Valerie. Welcome, everyone. And I'm excited to talk about family history and discovering your family history. It is something that is very near and dear to my heart, and it's incredibly valuable. As the host on Genealogy Roadshow, one of the things that I took away from that experience is how family history provides such a sense of identity and belonging. And when you have folks who don't know a lot about their family history and they discover something throughout that process, what it does for them is it changes their identity in a way. And it sometimes creates closeness among family members. And then you are also able to appreciate some of those family traditions, some of those things you might have taken for granted, some of those family customs and values. And then with finding out your family history, you can discover if there are any patterns that are represented or presented across various generations. And these may be things that you didn't know. A lot of times as you go through this journey of discovering your family history, it may trigger your memory or jog a thought about something with your grandmother or a parent or aunt or a great aunt that you never looked at before. Next slide, please. And so for mental health family history, this can be, and I know that we had a majority of folks who are comfortable, some that are somewhat comfortable in discussing this subject. This can be tricky to talk to families about. One thing I want to stress, and I will stress throughout my portion of this presentation, is that when you're starting on this journey, you never know what you're going to find. And it's really important, I think, for you as you go on this journey to take a step back and ask yourself, am I ready to receive the information I may find out? Because I have seen that throughout my practice and throughout the years of doing genealogy. So knowing if certain mental health conditions run in your family is helpful in having individuals proactively seek treatment and support. And while this can be difficult to discuss with family members, I think it's important to share with them, and I'll talk about this a lot more later, but I want to say it here as well, to share with them why you're on this journey to discover the mental health family history. Next slide, please. So how do you start this journey? For anyone that is participating, these tips are really tips for if you're just getting started in family history or genealogy in general, right? We always say, start with a conversation. Talk to your parents, your grandparents, siblings, aunts, uncles, cousins. We also have something in starting these conversations that we call the FAN network, which is friends, associates, and neighbors. it may be a little bit more difficult because you're talking about something so sensitive, but sometimes when we think of families, we may not have a traditional family, so to speak. So anyone who might have had a connection to someone in your family that may have known your grandparents or your parents, if they are no longer with you. And then any information that you find, document that. It is so important to document that information. And what we do and what we say is to really kind of cite your sources. And what I mean by that is when you're having these conversations, just have a document that states who you had the conversation with, their relationship to you, the date of that conversation. And we'll talk about ways in which to record that. We also saw earlier that there's a resource available, a mental health family tree. So this information can be used to feed that as well. And then seek assistance from the healthcare professionals in your area, as well as utilize all the online resources, especially those that are being provided for you today, as well as the ones that Families for Depression Awareness provides on their website. Next slide. So strategies for overcoming barriers. This one is really to maintain patience and persistence. I have used the story in genealogy a lot around my grandfather who passed away in 2021. He was 94 years old. But throughout the time in me doing genealogy, and I've been doing this for over 20 years, it was very, very difficult for me to get him to talk about our family. And I'm not sure why. I'm not sure if he thought perhaps I was going to use that information, and not against the family, but maybe to share it with someone outside of the family. I'm just not sure what his motivation was for not telling me that information, given that I'm involved in this profession. So when you are talking to family members, just remember to maintain your patience and persistence. And I know sometimes it can be frustrating, but get advocates within your family, involve other family members or relatives. Sometimes there's always that one aunt that knows everything. There's that one family member that someone has a better relationship with that you're trying to get information out of. So include them as well to help you overcome the barriers of getting this information. And then you can consult public records and documents. So I'll go through each of these. When we think of birth certificates, right, one important thing to remember based on where you live or what area you're researching, right? If you've moved, you're born in Virginia and now you're in Massachusetts or whatever, the biggest thing to understand are the laws related to the state in which you're trying to get the information. So I repeat that, the laws related to the state of where you're trying to get the information. So if you're trying to get a birth certificate in Virginia versus Massachusetts, there are going to be two very different steps for that. And the way in which you figure that out is to go either to your health department website. They should have something on there. They will let you know, sort of what the requirements are. There will probably be a fee associated with it. But the other thing is sort of who has access to those birth certificates, right? The other thing is typically within most states, I would say, birth certificates sometimes, depending on the state, are closed for 100 years. But again, that depends on the state. That's a very broad statement that I made there. And so you need to check the laws for your state. The same as with death certificates. Another thing to remember, or one thing to remember about a death certificate, is that it is only as good as the informant. And that is the person providing the information at that time. And so while you're on this journey, we have discovered, and I have discovered in my own genealogy and working with clients, that sometimes even the birth certificate has been incorrect. And definitely the death certificate lacks a lot of information. And so with death certificates, it's only as good as the informant. Understand the laws for the state in which your relative or ancestor passed away, or where you're looking for that information, and if you can get access to it, because they are restricted. Most death certificates, I think, are 50 to 75 years post date of death, but that just depends on the state again. And then with marriage licenses, those are also going to be records that are governed by certain timelines, depending on the state. So for newspapers, there's a site called Chronicling America through the Library of Congress, which is free. You can get information from there. Also check the local library for the place in which you're looking for the information. You can actually see if they have newspapers. If the state archives has a newspaper project, I know they have one in Virginia. And I mentioned Virginia a lot because that's where my ancestors are from. And so for all of these, when you're looking at public records and documents, know the laws of the state you're looking at, look at multiple sources, and understand that for these records, it's only as good as the informant, especially with death certificates. And then if you want to do genetic testing, you can do that if it's necessary and appropriate. Next slide, please. Oh, next slide, please. Thank you. So how do you start conversations? One of the things here is being able to choose a safe space or an appropriate time or place. And what I mean by that is, you know, you may be eager to learn this information, but starting this type of conversation with someone, maybe around other relatives, they may not feel less comfortable, or starting the conversation, you know, during Thanksgiving dinner, if you celebrate it, or any holiday dinner, may not be appropriate. So usually one-on-one is good for these types of conversations because you're going to have patience and you're going to be persistent. And so you're going to have more than one conversation. And then approach it with empathy and respect. Every time I approached my grandfather, it was really just kind of the two of us. Maybe my mom was in the room with us, you know, and I really tried to understand why he was so resistant to give me any information. What was his point of view, right? And every time I came away with maybe a little nugget of information, but if not, I use that to basically say, okay, well, let me see how I can approach it the next time. And use open-ended questions and, you know, active listening. The most important thing here is to listen to what they're saying, to make sure that you're not anticipating your next question while they're talking. And a question here that really shows an example is, can you tell me more about our family's health history, right? And then you approach the subject around any mental health experiences and sharing your motivations. Why are you doing this? And it's because you want to know, because you are obviously attending this webinar to find out ways to start these conversations. And then use storytelling and personal anecdotes as well to help you understand or to help them understand why you're trying to uncover this information. Next slide, please. So the additional conversations, be patient and understand it. A lot of these conversations are ones that you may get some information, but there's not a follow-up. Seek some type of, you know, support for cultural resources. I know in some cultures it is very difficult, or it's keep the past in the past. Why do you want to find out about this? Use folks to help you kind of uncover this information, that trusted advisor, that friend of your relative, maybe that aunt or someone they're close to, and then respect their boundaries and privacy. One of the things I never did with my grandfather is press him. I always acknowledged when he didn't want to talk, and then I came back to him again and again. And you know what happened eventually? Eventually, I ended up getting nuggets of information about our family history from him without me even asking. And I learned more because he became comfortable over time. And that took years for me to get there, but I think it's important to do that. And that's why you have these multiple conversations. You don't learn about anything or anyone in one conversation. We develop relationships over time. And you're talking to someone about a subject that may not be comfortable talking about, right? And so now if you have these multiple conversations, you build up that trust. You've used your storytelling, you've used antidotes, you've created that safe space, and they feel comfortable talking to you. Next slide, please. So when you're discussing these sensitive topics, I mentioned this before, be prepared, prepare yourself emotionally for this. You never know what you're going to find. You don't know how the other person is going to react. And that is one thing as well. So prepare yourself emotionally, be compassionate, try not to be judgmental, be honest and transparent. I mean, that's the most important thing, creating trust with anyone. If you're honest and transparent about why you're doing this, why you want to know this information, and then, you know, just kind of be sensitive in sharing this information with family. And then respect their boundaries, right? So some people may not be open to hearing what you have to say or the information you're providing to them now that you uncovered it. But I think that if you encourage kind of these open and ongoing conversations with them, then that would, that helps over time. But the one thing is also, as you're patient, as you're persistent, passionate, and non-judgmental, this is not a one and done conversation. These are multiple conversations. And as you're sharing this information with someone, offer them support and resources. You are sharing something very sensitive that they have to process and digest. And so it's really, really important that you actually offer support and resources to them. And there are resources that are available that have been shared as well. Here, next slide, please. All right. Well, that's it for my portion of the presentation. I hope everyone learned something from that, but just be patient, be kind, and enjoy the journey.
Thank you so much, Kenyatta. I want to remind everybody that you do have a question and answer box on your bar at the bottom of your Zoom screen. And feel free to enter your questions there, because we are going to have question and answer with Dr. Cohen and with Kenyatta very shortly. Just want to remind everyone that there are resources, as Kenyatta mentioned, for you and for your family members, should you find out that you do have a history of mental health conditions in your family, or you are struggling, or one of your loved one is struggling. If they're just looking for some general information and resources, 211 works wherever you are, and you will be routed to someone who can help you find local resources. If you are looking for a therapist, Psychology Today has a great search tool. And if you're looking for a provider of color, there are websites like InnoPsych that can provide you those directories as well. If you or your loved one is suicidal or showing signs of suicidal ideation, suicidal thoughts, you can now dial 988 from wherever you are, just the numbers 9, 8, and 8. You will also be routed to crisis resources that are local to you, and they can help respond in any situation. Texting home to 741 will bring people to the crisis text line for youth who are dealing with mental health issues. The Trevor Project has some great resources, also the Trans Lifeline. And we have a partner organization that we work with quite a bit, Courage to Caregivers. They offer virtual support groups for caregivers. So that's a wonderful resource. Just want to remind everybody, we're not ending yet. We are going to get to question and answer, but at the end, we will put a survey up. So if you cannot stay for question and answer, feel free to go ahead and fill out that survey, and you will be entered a chance to win Kenyatta's amazing book, The Family Tree Toolkit. So be sure to do that if you have to depart a little early. And we also have a resource called the Family Action Plan. So if you know you want to get moving on gathering some of this family mental health history, or you have a loved one who is struggling with depression or bipolar disorder, and your family needs to get on the same page together on how to address it, then our Family Action Plan is a wonderful resource. And all of these are free on our website. We also have our Building Your Family Caregiver Toolkit. This is really important because family caregivers are often overwhelmed, and they don't know where to start, and they don't know what their role is, and they don't know how to practice self-care. So our toolkit is a great downloadable resource that can help you. Our program is supported by Takeda Lundbeck Alliance, Sage Therapeutics, Alkermes, Janssen Neuroscience, and the Massachusetts Department of Public Health. We are also supported by individual donors. So if you're somebody who donates to us to support our mission and allow us to offer free programming and free resources, we appreciate you, and we accept donations so that we can continue to do this important work. Dr. Bruce Cohen and Kenyatta Berry are going to answer your questions next. Again, if you have to log out now, please do fill out the survey and consider making a donation to us. Otherwise, we are going to get right to the question and answer. I see things coming in the chat. We will be checking the chat. We will be checking the question and answer. But I'm going to start. I'm going to ask Kenyatta and Dr. Cohen to put your cameras back on. And We're going to start with a question. I think this will probably go to Dr. Cohen that was submitted before the webinar. And the question is, are we at the point, or when will we be at the point when inherited mental health conditions can be located on chromosomes? Is that even a thing that can be done? And if so, when and how, and would that be helpful in any way to folks?
Potentially, yes. We already know, as I mentioned, hundreds and estimate thousands of genes that are relevant, and each gene is on a chromosome. So human beings have an awful lot of DNA, as you would guess, and it's not all in one cluster. A chromosome is just a linear strand of DNA containing genes end to end to end to end. And so each of the genes that has been found to be associated with any particular mental illness has a site on one of the chromosomes, but they're all over the place. So some will be on one chromosome, some on another. There's no chromosome that doesn't have a gene that's been associated with a psychiatric disorder. The technology, and I'll try to keep it brief, the technology people are working towards is to try to understand, if you look at the hundreds of genes that are most determinative, most important in determining risk, can you come up with a sort of a score which would tell you, oh, if you've got these 5 and those 6 in a particular combination, are you more at risk or less at risk for any particular condition? We're just not there yet. Could it happen? Well, it will happen if we keep ourselves safe enough and work through some current very difficult times in the world. The problem is, as I mentioned before, people tend to think of disorders as categorical. As I mentioned, that you either have this condition or you have that condition. It just isn't going to work out that way. If you look at people who are suffering from cardiovascular disorders, it's not really all the same condition. And if you look at people who say, I'm seriously depressed, it's getting in the way of my life, it's not always for the same reason. So that adds a level of complexity. The two different people who both have a very similar complaint about being depressed and very similar problems may have completely different genetic underlying reasons why they were at risk. Does that make sense?
It does. It does.
Okay.
Thank you for that answer. So maybe one day, I guess.
Yeah, no, it's possible, but we're really not that close yet.
Okay, great. So we have a question for Kenyatta. Do you think professional genealogists should be better prepared / educated to deal with mental health issues arising in their research? And if so, what would that look like? I think this is such an important question because people might go digging and find out, so-and-so relative died by suicide, and then you have to figure out how to handle that. So should professional genealogists be better prepared to deal with mental health issues arising in their research, and what would that look like?
Great question. I really appreciate it. I'm actually in Salt Lake City for the Professional Management Conference, and it's a bunch of professional genealogists. So we will be talking about this. We do need to be better prepared. I mean, I think as a genealogist, when we're sharing information with folks, we have to deal with that initial reaction from our clients. And we need to understand how to relay that information in a way that's not just matter of fact, right? Some folks can do that, but then also how does that impact the person, especially when you're talking about mental health? So yes, we need training on that. We definitely need to be more prepared. I would love suggestions on how to get us there, because I think as more people try to understand their family history, understand their family health history and mental health history, we will encounter this more times than not. And the other thing about genealogists is typically, I am not one, but most of them are very introverted. So being able to, share that information in a way and then not have such a reaction to, oh my gosh, this person is upset. How do I deal with it? But having the tools to be able to do that. So I am all for it. I will be talking about it with my peers tonight, but I do think that's something that we definitely need to do.
Thank you for that. So a question that came in before the webinar during the registration period. What is there a genetic component to Dr. Cohen, or what is the explanation for why something like depression or bipolar disorder would skip these group of family members and the others? I think part of it is how you were explaining earlier about how complicated genetics are and how complicated genes are, and that there may not necessarily be a rhyme or reason to why this relative got it and this one didn't. Why in this family, 3 of the children have depression, but in their cousins, none of them do. So, or maybe in one generation you had several suicides, and the next one, none at all. So is there a genetic explanation for that? Is it more of what you were talking about in terms of family culture? How can we explain why it happens in the same family tree, but hits different generations or even different family units?
Right. So that's a great question, and you hit on the reasons, of course, but just to add a little more detail. First of all, if you, as we know, if you know that a single gene is not the cause of almost anything, then you're not going to see a family pattern in which, say, one of the parents has it, then some of the children have it, and then some of the grandchildren have it, because it's not so simply determined. Even if it is a single gene, whether a child would have it would depend on whether they got it or not. But your very interesting question is, why would it disappear for a generation and then appear in the next generation? And the answer to that is exactly the things you referred to. So in one generation, the children are getting some genes from a mother and from a father, and they don't all get the same genes. So some may get the susceptibility and others may not get much susceptibility. Now, in the next generation going down, another set of genes comes in, right? And the person, there's an old song in genetics, by the way, which is called associative mating, which is that people tend to marry people with very similar psychological traits. This is not always true, but there is a considerable degree of tendency. So the next set of genes coming in may also have some of the genes that put a person at risk. So the skipping of the generation is not because the genes aren't there. It's because there's not enough of so-called load, enough of them to make you very susceptible. But you also put your finger on the other factor, which is, what was life like? How were you reared? And we mustn't forget the simple things that our society doesn't get right all the time, which is everybody really should grow up with a good diet, access to exercise, and a good education. Now, if people don't get those things, they're at more risk for all kinds of troubles, including various medical disorders and psychiatric disorders and social problems. And we don't pay enough attention to that. So it's all of those factors interacting that give you the pattern that you're talking about.
Thank you for that answer. Kenyatta, I'm going to go to you. I'm going to paraphrase a question that came in and get your take on it. One of the things that can make sharing a family history, once you've collected it, difficult is some people might want to hear it, some people might not, depending on, as Dr. Cohen has explained, depending on the degrees of separation, it may not be as helpful, but it can just be informative to people to know. How do you go about sharing that sensitive information without being labeled the family gossip, or having members say, why are you digging up all that old stuff? Uncle so-and-so died so many years ago, and why are you pointing out that this happened, or why are you talking about your sister like that? How do you navigate? You told us very well how you do it on an individual basis, getting a reluctant family member to kind of open up to you, but how do you share that information, which is important, and frankly, it's not so stigmatized in other health conditions. If you have a certain breast cancer gene or breast cancer heritability in your family, people will say, oh, make sure you know this, make sure you know that, and it's shared. But when it comes to mental health, you're a gossip, you're dredging up old issues. And I would assume that there's some crossover with substance use disorder and things like that, some of these more stigmatized health conditions. So how do you do it? What would be your advice?
Yeah, and you're right. I mean, I talked a lot about the individual piece of it, because I think that's where it starts. But as far as once you figure out what, how do you share the information once you find it out, right? And um, kind of one, the stigma being like the family gossip, and kind of dealing with that is really around sharing the motivation with them, right? I am telling you this because I started doing this because, right? What was your personal motivation? Who you talked to about it? I talked to aunt so and so. I talked to dad. I talked to grandma. I talked to this cousin. And so you start by showing a pattern, or at least a path that you took to get the family story, to get the information that you're sharing with them. So you're showing them that I deliberately did this from step 1 through 5 or whatever it was, and now I'm here to share it with you. If I were just the family gossip, I would have went to this person, shouted it out. I went to that person, shouted it out. But I went to all these other people and aligned with them to get this information. And I'm sharing it with you because I feel it's important for you to know. If you're not ready to receive it, that's okay. I can come back. And like I mentioned, as far as in my last slide, we talked about giving them support and resources, because you may share one piece of information and they stop, they shut down. Then don't just let them kind of stew about it themselves, but say, hey, if you're not ready to receive it, here's some places you can go to understand it a bit more. So sharing your motivations, who you talk to, and letting them know that you're not doing this to be the family gossip, but you're doing it because you think it's important for them to know.
Great answer. Great answer. Don't give into that label. You don't have to be labeled a family gossip. Just you're sharing important information. That's good to know. We are getting some questions in the chat, and we had one that was sent just to us. I will ask the person who asked about the Venn diagram. I'd be happy to pull it up and ask Dr. Cohen a specific question. So can you please resend your question and say exactly what you want him to talk, which part of it you didn't understand, so we can maybe go back to that. So resend your question, please, and clarify which part of the Venn diagram you wanted more clarification on it, and maybe we can go back to that slide. Another question in the chat, and Dr. Cohen, I'm going to give this to you. There's a lot of talk about trauma and how it can affect generations to come. This particular question is, how can PTSD impact future generations? And certainly if you want to talk about the concept of generational trauma at all, you can weave that in as well.
Sure. So I didn't talk about what's called epigenetics. And what epigenetics is that DNA is floating around in the nucleus of the cell, and it's interacting with all kinds of other elements. And when I mentioned the issue of genes being regulated, turning on and off, the factors that regulate whether genes are easy to turn on or turn off are sometimes actually stuck on the DNA, chemically stuck on the DNA. So there are a few small molecules that are attached. There's a debate as to whether some of those factors that get stuck on the DNA can be passed from generation to generation. In that case, it becomes less epigenetic, which means on top of the genes, than just genetic, of course. But there's growing evidence that a variety of circumstances, trauma is one of them, famine is another one, can cause changes in the DNA that go from one generation to the next. Now, the other factor too, on which I think we all agree, is that, and we've all discussed, is that the way we're treated in a family has long-lasting effects. It's not generally true that what some people were saying decades ago, that not being very nice to your children puts them at extremely high risk of a problem. That's not true. But being abusive of children, verbally or physically, does increase their risk for psychiatric disorders. And that that's a passed down matter. Sometimes a parent is so distressed, him or herself, that it's very hard for that parent not to do things which could be difficult for the children. As for PTSD in particular, PTSD is not all that well understood. It hasn't been studied adequately. It's only really been properly looked at in the last decade or two. But the earliest reports go back to about World War I, and obviously, I mean, war combat is one of the areas where PTSD is obvious. Another place is in family relationships where people are physically and sexually abusive. But the studies that have been done of PTSD suggest that traumatic experiences bring out susceptibilities that, and as I mentioned before, all of us are susceptible. It's just a question of degree. If you turn up the stress enough, or you are in a traumatic enough situation, then even if you have low susceptibility, you may end up having symptoms of depression or anxiety, even hallucinations and trouble with attention and thinking. And that'll affect the way you interact with other people. So that has a downstream effect beyond you.
It certainly does. Thank you for that answer. Kenyatta, I'm going to ask you a question about cultural considerations. And then as you're answering, I'm going to pull back up the slide. Dr. Cohen, we did get a little bit of clarification from the person who had that question. So we will bring that slide back up while Kenyatta is giving her answer so that you can then address the question afterwards. But Kenyatta, there are certain cultural communities in which it is even more highly stigmatized to talk about mental health than others. Can you address what kinds of tactics to use if you're from a community where it's just taboo to talk about those subjects and there isn't really a good language or history of having those conversations, and how to kind of overcome those barriers?
Yeah, so from a cultural perspective, I'll speak from my experience as an African American woman, and even in my own family, having discussions as it relates to mental health within, as my experience in the African American community has been difficult, to say the least. And a lot of times, the bringing it up and wanting to even talk about it is almost as if you're looking for a problem in someone. You're trying to find out, what was wrong with this, or something wrong with a person, I should say, which is not what you're doing. So one of the ways to overcome that as you deal with these cultural things, and that's, as I speak just from my experience in my own family, is as we see those barriers pop up, again, it's important to stress kind of your motivations for doing it. I think it's important as well to say, look, I know this is a sensitive topic. I know we don't want to talk about this, but I'm coming from a place of where I want to understand it. And I want to understand it for my children, for my grandchildren, for our family. I think it was kind of interesting. I had a client once who mentioned during a presentation that her grandmother would, during the summer, let's say, she would, at a certain period of months, she would just stay in bed all day, and no one ever talked about it. But they just knew during these months that Granny was going to be in bed all day. And how later on, as she's, well into her 60s, understanding that, what that really meant, and then regretting she didn't have the conversation. So I say, to overcome those barriers, let them know why you're doing it, where you're coming from, your motivation, but also when it's from the cultural perspective, say it's important that we talk about it. It's time that we talked about it. And, and it's nothing to be ashamed of, or to be kind of like, well, if I tell you this, you're going to think of this person differently. That's not true. I'm really doing this because I think it's something we'll talk about. And as a family unit, we'll probably be closer, and then we can better understand each other. So those are the things that I have used in my own kind of work. And then again, that persistence and patience is really important.
Excellent. Thank you. Dr. Cohen, we have a comment with regards to this slide, and I'm just going to read it out for folks, just so that we're all on the same page. I'm amazed regarding the overlap and that it reflects how difficult it is to diagnose a person. Thanking the speakers for their help. But can you speak to how, if you look at this particular slide and see how much overlap it is when something pops up in your when you start exhibiting symptoms, psychiatric symptoms or behavioral health symptoms, and you're trying to diagnose a person, but it could fall within multiple different diagnoses. How do you approach that, and how could you, what advice would you give family members for understanding that process?
Right. And if I may, I'd also like to not only confirm something Kenyatta said, but add that I wish we as a society would speak more about psychiatric disorders. When you go to school, you know, they'll tell you about a variety of conditions, but I know they didn't used to talk about depression or anxiety very much. And I think more education, more sharing, and also the simple fact of acknowledging we all have quirks. You know, we all have times when we're in a bad mood, or we all have times when we do something stupid. We all have times when we're not thinking clearly. I think we can reduce stigma if we can be more open, and that I think will help with understanding. None of us can do that right away, but maybe we can get there. The Venn diagram is to be taken with a grain of salt. I mean, I had to draw circles, and I actually drew those, and I was moving them around. And but the key issue is what the person asking the question realized, which is that with all these genes shared between different conditions, how can we be confident which bucket you're in? But I'm denying the buckets. And we've actually written a series of papers requesting that the field stop talking about schizophrenia at all. It's a much misunderstood word, and it's not helping with stigma. And especially if you watch movies and read the media, you know the kinds of things that are associated with schizophrenias, even though most people with schizophrenias are having problems, but they're not hurting anybody else. You know, and especially if they're getting good support and treatment. So what we've pointed out is that what you do, and by the way, we did a survey of hundreds of psychiatrists and asked them, do you use these diagnoses when you do your assessments? And they said, not really very much. They said what we look for is somebody depressed? Are they having trouble sleeping? Are they not eating correctly? Are they anxious? Are they having attacks of anxiety? Or are they chronically anxious? Are they having trouble thinking? Are they distracted? Are they hearing voices? Do they have thoughts that are bothering them? Those kinds of things, which are more along the lines of symptoms and groups of symptoms, which are sometimes called syndromes. And then you ask yourself the question, because this is part of personalizing your interaction with somebody. You pick a treatment according to the best evidence that you know that might address what somebody is experiencing.
I'm going to stay with you, Dr. Cohen, with a question that was submitted live. Do treatment methods that work for one family member tend to work for other family members?
You know, I thought I had that in a slide, and then I didn't notice it because we discussed that when we all chatted a week ago or whenever it was. Yes, but it's like everything else. It's a tendency, but you can't totally rely on it. But there are a variety of reasons why what's good for one family member might help another family member. One is because they may have very similar conditions, underlying causes for why they're not feeling well. The other has to do with the way drugs are absorbed and metabolized and excreted. So, because those are determined heavily by genes too. So it's a very good question, and it's another question I do ask people. I said, do you have anyone else in your family being treated with for any condition, you know, but certainly a psychiatric condition? What are they getting? You know, what kind of treatment?
Thank you very much. Kenyatta, do you think DNA test takers have the obligation to alert an estranged or newly discovered relative with a mental health history? I think the question is, so I'm going to rephrase it a little bit because as we pointed out, I don't know that you would take a DNA test that would say that you have depression or bipolar disorder, but I think what they're trying to say is that, let's say you discover relatives that you didn't know you had, and on your side of the family you have mental health history. Do you share that, or how do you share that with that family? The DNA test is a tricky thing because people, they get their DNA test, and as Dr. Cohen was mentioned earlier, they find out daddy isn't the daddy, the mommy isn't the mama, the brothers and sisters have different parents. And so
Right.
What would you say about surprise information through DNA testing, and then obligations or conversations about sharing health history in general after that?
Yeah, so and I think the thing with DNA testing is it's misunderstood. I'll just say that and leave it there because we can have a whole nother discussion about that. But I really think when you get this, if you know your family's history and you've identified or done work on your family's mental health history, and for that particular side of your family, maternal or paternal, you find an aunt or a cousin, right, or a relative, whether it is a half sibling, a full sibling, a cousin, whatever, and your quote unquote obligation to share that information with them. I think it goes back to everything we've discussed so far. Really, what's the motivation, right? And how are you going to receive that information? Typically with DNA testing, and you get your DNA matches, these are people you don't know unless you've done extensive research, right? So this is someone new. Just reaching out to them on just the average family history, saying we're related, 9 times out of 10 people don't even respond to you for that. So if you're going to try to reach out to someone and say, or you feel like you need to reach out to someone and say, hey, by the way, this is what's going on our side of the family, that person doesn't know you. They not be open to receive the information. And so I don't feel like you have an obligation to tell that person. You need to establish a relationship with them first before you even think about sharing any type of information, any type of family history. I always caution people, once you do a DNA test, the one thing I don't like is if I get a DNA match and someone says, hey, Kenyatta, we're third cousins, can you send me your tree? I've been working on this for 20 years. I'm not just going to hand over all my information. So, it's like, if you're contacting that person and say, I've been working on our family history for 20 years, and I'd like to tell you about a mental health history, that's going to be a hard stop, I think, with anyone. So establish that relationship, the motivation, and then figure out why, you want to share that information, because you don't know anything about them. So get to know them first before you do that.
Very good. Thank you so much. I think we have time for one more question, and then we have a poll. So everybody stick around because we have a closing poll. So Dr. Cohen, I'll send this to you, and this will be our last question of the evening. We have an extensive history of mental health disorders. I'm assuming that in our family is the rest of that sentence. How do I prevent this from continuing into the next generation?
Yes, that's a good question, a smart question, but a difficult one. And a background piece of information is to remember there's very few families that don't have some mental health history, and that's just because mental health issues are common, that it's just part of the human condition. And you can't change your genes, at least not now. and you may be asking me, well, when will we be able to? I think not for a long time, nor would we necessarily want to, because genes have multiple effects, and the same gene that puts you at risk for something may also make you special in some other way and give you some other ability. So you can't change your genes, but what you can do is work on your environment. And the environmental factors can be very, very helpful. So first is be compassionate, caring, and supportive of one another. That reduces risk. A second thing is, as has been mentioned, eat a good diet. Americans are not very good at that. And And some people around the world, of course, don't have much choice, but a healthy diet is important. Regular exercise has been shown to reduce the risk for any number of neuropsychiatric disorders. And those things are crucial. There's a last one, and this one's tough, and that is avoid unnecessary stresses, and especially extreme ones. We often get stuck in situations and we don't move ourselves, and we know we're in a bad situation, but we don't engage with this. And this overlaps with what Kenyatta was saying, which is be patient, be thoughtful, get information, and then make change for yourself and for others around you in a beneficial direction. Those things make a difference. And I'll go back to one more comment. As you noticed from the slide somewhere before the Venn diagram, maybe 50% of the determination is genetic. That leaves a lot of wiggle room to work with other things.
Thank you for those inspirational words. Very, very positive way to end the question and answer. Want to ask everybody who is on the webinar, how much did you learn, or how much do you know now about gathering and sharing family mental health history? Give you all a few seconds to answer that question. Oh, I can definitely see people have moved. We have no more sums. Give you all about 2 more seconds on that. Okay, excellent. I'm going to share these results. Looks like we now have 64% of people said a lot, and 36% of people said a good amount. So we definitely had some movement there. That's awesome. We're so glad that people learned from this webinar, and deepest thanks again to Kenyatta Berry and Dr. Bruce Cohen for sharing your knowledge, your expertise, and your advice to the folks watching. If you're watching this recording and you're not watching it live, we hope that you are getting a lot of information that you can use in your life and with your family going forward. Please complete our survey. Start your mental health family tree. Start asking those questions. If you're watching this around the time it was recorded, the holidays are coming up. So as Kenyatta said, maybe not at the Thanksgiving dinner, maybe not there, but you have relatives in town who you know are just the historians of the family and can give you some good information. This might be a time to find that moment, that quiet moment to talk to them. If you're watching this at some other time, just take the opportunities you have to start gathering this information, because it really can be helpful. And of course, visit familyaware.org to access our resources and the other tools and support that we offer. Thank you, everyone, for watching. Bye-bye.